May I now request Dr. Jalaluddin Muhammad Rumi, who is an assistant professor of neurosurgery and works with epilepsy surgery, to, to talk about the surgery in epilepsy. Where are we now?
Honorable Chairperson and respected teachers and colleagues, Assalamu alaikum and good evening. I am Dr. Jalaluddin Muhammad Rumi to talk about epilepsy surgery with the title, Surgery in Epilepsy, Where Are We Now? As already mentioned by Dr. Selim Shahi, the refractory epilepsy is 30 to 40%. And globally, candidate for surgery is around 10 million. But epilepsy itself is complicated. Epilepsy surgery is much more complicated. So I want to show one case, illustrative case, and then I will talk about the principle of epilepsy surgery, and finally, where we are and where is our challenges. So you see here, 20 years old patient having focal seizure involving left upper limb, left side of face, and trunk for over 4 years. A lot of drugs tried in their maximum doses, but ultimate result is nothing. You see the lesion in the T2 weighted images. The lesion is just over the precentral gyrus, over the motor cortex. Now we have found the epileptic lesion, epileptogenic lesion, but epileptogenic zone, the zone required to be excised, is a bit wider than epileptogenic lesion. And in this particular case, excision means definite neurological deficit. We considered surgery for the fact that you see in the left side there is homunculus, and in the right side more expanded view. In motor cortex, inferior Rolandic corticectomy could be done with acceptable deficit. Inferior Rolandic corticectomy means the area below the thumb. So if we excise the area below the thumb and the lesion is within that region, the neurodeficit will be acceptable, patient will get better. But if the lesion is more higher level, then patient will be paretic in his valuable hand. And then we have planned for surgery with much precaution to reach. You see, the lesion is not a tumor, and such lesions are very difficult to differentiate on naked eye or under microscope without added support. We planned our incision craniotomy, and we reached the precentral gyrus and central sulcus using neuronavigation. And then we have done cortical stimulation to identify the hand region, lip region, face region, tongue, etc. And you see in the left is the scenario of cortical stimulation. In the right side, we have marker over the cortex indicating the region, corresponding region. And then we placed a subdural electrode to see before excision what is the condition, what is the electrographic change. And this is the electrocorticogram. And then we went for excision under aortic craniotomy. Again, after excision, we again placed a subdural electrode to check what is the status of EEG signals. And we have found that there are still some signal from the posterior leads. And then we further excised. And so far, patient is in our follow-up and doing well. He is happy with present status. In this particular case, we have used many armamentarium. We used cortical stimulation, electrocorticogram, neuronavigation system, and aortic craniotomy. But now, what is the principle of pre-surgical evaluation? Very first thing is to exclude pseudo-seizure. Misdiagnosis in epilepsy is quite common, especially from the primary care providers. And there are a large list of epilepsy imitator in all textbook and also in ILA website. And it is told that when patient comes for pre-surgical evaluation, At least almost one-third patient are actually not patient with seizure. They are patient of pseudo-seizure. And another subgroup are patient with pseudo-refractoriness. Because there are so many medical treatment for epilepsy now, including steroid, IVIG, ACTH, and newer and older generation anti-epileptic drugs. The common mistakes in medical treatment is that the choice of drug is may be wrong or the drug is suboptimal. Dose is suboptimal. And then third issue is etiology. If a patient has genetic or metabolic diseases, progressive metabolic diseases, a surgeon has little to do with such patient. And fourth issue is still there is a chance of remission. You know, classic example is benign Rolandic epilepsy. Sometimes it is difficult to treat, difficult to control the seizure. But we know that after certain age, it will patient will get remission. So surgery should not be considered. And when all these groups are excluded, the final issue is, okay, the patient needs surgery, but where is the focus? And to identify the epileptic focus is really challenging. What are the tools for pre-surgical evaluation? Very first thing is history and clinical examination. And in this part, routinely, things start from the pattern of delivery, birth, perinatal asphyxia, perinatal infection, postoperative febrile seizure, history of febrile seizure, birth trauma, and CNS infection, etc., etc. And possibly the most important one when epilepsy surgery is considered is seizure semiology, because seizure semiology is the main thing to lateralize and localize the epileptic focus. And seizure semiology has a lot of value. Details was already discussed by Dr. Anayat Hossain. Now, neurophysiological assessment, there are two main subgroup. One is electroencephalogram, another is magnetoencephalogram. Both are almost basically same thing, but magnetoencephalogram is based on magnetic field. Establishment cost is very high, and this is, though this is non-invasive, highly sensitive, but it is available only a few centers worldwide. Electroencephalogram is cheap, available, but it has many varieties. Interictal EEG shows interictal epileptiform discharge. It indicates irritative zone. It doesn't indicate epileptic zone. And its sensitivity is poor. There is many cause why it's sensitive. I don't want to go further. The second thing is video telemetry or long-term video EEG monitoring. Actually, for epilepsy, first investigation is interictal EEG, but for epilepsy surgery, first investigation is video telemetry or video EEG monitoring. It is very, very helpful. Usually, drug is withdrawn for a few days. Patient is kept in admission with continuous monitoring and video recording so that pseudo-seizure can be excluded, seizure focus can be identified, and EEG pattern and seizure classification can be done nicely. But even video EEG is not always enough. And in such situation, we have to go for invasive EEG monitoring. Invasive EEG monitoring means doing a craniotomy and placement of subdural EEG electrode, and then again going back to the video EEG monitoring room and recording for a few days. Another form is stereotactic placement of depth electrode, and again going back to the video EEG monitoring room and recording for a few days. And in all these cases, usually drugs are withdrawn to provoke seizures so that we can come to a conclusion. And then structural and functional structural MRI in epilepsy protocol. This is helpful actually when EEG, in terms of epilepsy surgery, epilepsy can be classified in two types: MRI positive epilepsy, MRI negative epilepsy. In MRI positive epilepsy, there is a lesion, and this lesion is responsible for the seizure. And things are quite much easier when there is a lesion in the MRI. and this lesion is concordant with the seizure semiology and EEG findings. But when there is no lesion in the MRI, or MRI lesion is not related to the particular seizures, then it is quite difficult. Other than MRI, there are functional MRI. Functional MRI may not be that much important for focus identification, but is important for further planning of surgery, because when there is planning for hemispherotomy, you have to know where is the whether it is dominant side or non-dominant side. Then neuropsychological assessment, it is a routine practice before all epilepsy surgery, and it also has some localizing value. For example, if a patient in neuropsychological assessment, it shows that he has some deficit in verbal memory, it indicates that the lesion is from the left side or dominant side. Intracarotid amobarbital procedure, this is the gold standard procedure for speech area localization, and but less commonly used. I have advised for a few cases for order test in our intervention, but I didn't get any response. Electrical cortical stimulation is also a high-tech procedure. When intracraniotomy done and electrode placed, through this subdural electrode, cortical stimulation could be done to see the relation of the lesion with the eloquent cortex. Now, epilepsy remediable surgery, by surgery, there are so many lesions. Malformation of cortical developments, there are hemimegalencephaly, focal cortical dysplasia, these are also malformation. Hypothalamic hamartoma, another malformation. So these structural conditions frequently refractory. Sometimes they could be they are operable, sometimes they are not. Suppose when there are so many lesions and involving both hemispheres, then it is not amenable for surgery. But when there are single lesion and away from eloquent cortex, it is quite easy and the result is good. Even if there are multiple lesions, but single one lesion is responsible for most of the seizure, if we excise this lesion, the seizure frequency will significantly reduce. So even there are multiple lesions, still there are possibility of chance of surgery, chance of giving some benefit by surgery. In hemimegalencephaly, brain gradually become enlarged but functionless and epileptogenic. You can consider it as painful, useless foot of peripheral vascular disease. So in peripheral vascular disease, a painful, useless foot, we can excise it and put a painless artificial foot. In hemimegalencephaly, the brain is enlarging and non-functioning. Patient is getting hyper, hemiparetic, hemianopic, and frequent intolerable seizure. So hemispherotomy gives her or him the freedom from seizure and he get a better quality of life. And if it is done earlier, in the early age, during the age frame of plasticity, suppose below 7 or 8 years, the patient's the neurological deficit improves over time due to plasticity. Rasmussen's encephalitis, another inflammatory condition, occurs in childhood, and gradually brain become atrophic, and hemispherotomy is a choice for this condition. Temporal lobe epilepsy is most common condition for epilepsy surgery. Two major subdivisions, mesial and neocortical. In fact, neocortical temporal lobe epilepsy is almost similar to the extratemporal lobe epilepsy. But mesial temporal lobe epilepsy is a bit different. Mesial temporal lobe means temporal lobe medial to the collateral sulcus. And this part also contains the limbic portion, hippocampus, fornix, and these are primitive brain, more and more epileptogenic. When there is a lesion, even a tumor, in this mesial part, you have to excise the tumor also amygdalo-hippocampus to get a better result. Epilepsy-associated tumor, in most cases, they have to be excised. excising only the lesion is enough in most cases, but when it is in the mesial temporal lobe, this excision should also include amygdala hippocampus. Hypothalamic hematoma has two main varieties: infraventricular, which causes precocious puberty, and intraventricular, which causes gelastic seizure, decrestic seizure, and generalized tonic-clonic seizure. And always it is drug resistant, and treatment option includes craniotomy and surgery or aesthetic radiosurgery. Lennox-Gastaut syndrome, already mentioned in details, my senior. The thing I want to note about Lennox-Gastaut syndrome, that there may be a structural lesion, and there may be multiple lesions, but maybe single lesion is mainly culprit. So surgery is an option. And even when there are so many lesions not amenable for excision, there is still chance of corpus callosotomy and VNS. There are so many literatures in favor of these things. The Landau-Kleffner syndrome, it causes acquired aphasia. Seizure is controlled by medication frequently, but there is one observation that even if seizure is controlled, the epileptiform discharge continues. And this seizure and epileptiform discharge is responsible for the aphasia. And multiple subpial transaction in this condition, by multiple subpial transaction, two group of surgeons showed better result. But there are some other reports that are not that much encouraging. So about epilepsy surgery, in broad category 3 subdivision: resective surgery. Resective surgery means resection of the lesion or resection of the lesion with amygdala hippocampectomy. And second one is disconnection. Generally, resective surgery is curative surgery, disconnective surgery is palliative, but this is not always true because disconnective surgery, hemispherotomy, the result is really good. Sometimes it can be considered curative, but corpus callosotomy is another disconnection surgery, but that not that much good result. In drop attacks, patients with drop attacks, corpus callosotomy gives 50% reduction in 50% patient. But one fact is that if in such patient corpus callosotomy done and in a short interval vagal nerve VNS is put, then in course of time these two procedures, combination of these two procedures give much better result. So neuromodulation is an option in epilepsy surgery. VNS is quite older procedure. RNS tried. So far, no conclusion about its value. But there are deep brain stimulation for epilepsy and deep brain stimulation to bilateral anterior nucleus of thalamus. There are multiple reports of very good results. Now, what is our status, our progress? About our progress, this is a journal published by Farhad Chaudhary et al. In 2010 in Asian Journal of Neurosurgery. They expressed their experience on 5 cases of temporal lobectomy and amygdala hippocampectomy. And in last 1 decade, we have done many intermedial temporal lobectomy, extratemporal resection. In fact, whenever there are lesion, MRI positive epilepsy, things are quite often we are doing. And we have done a case of functional hemispherotomy. We are a bit stuck up to some points. Why we are stuck? I want to end my speech by this. One first point is this awareness among patient and physician. Surgery is a valid option in epilepsy, but still, even many physicians are not aware of the fact. And localization of focus. When there is no visible lesion in MRI, for localization, we have to go for invasive electroencephalogram, but we don't have such things available around us so far. And ictal aspect also very important for localization. In our country, there are aspect, but none of the centers, they have aspect, but they don't do ictal aspect. They do interictal aspect. Interictal aspect has very little value. PET scan are available, but costly. And about choice of procedure, to choose a procedure is not straightforward all the time, especially when there is a lesion on the eloquent cortex. It is really difficult to make a decision, because only multiple subpial transection is a procedure for eloquent cortex, but multiple subpial transection as a standalone procedure is not that much encouraging. If the lesion is something like that, a part is in the non-eloquent brain, another part is adjacent eloquent brain, and if we excise the part on the non-eloquent brain and the remaining part we do subpial transection, that is fine. But if the whole lesion is in the eloquent cortex and we do only multiple subpial transection, it is not that much encouraging. And final thing is availability of the logistics. We have no video telemetry in neuroscience, no invasive EEG monitoring, no aspect, no PET, and no. So far, we haven't done anything for neuromodulation. My request, earnest request to our director sir, that we should have a comprehensive epilepsy management program and a functional neurosurgery unit. Thank you so much for kind hearing.